now I would like to introduce our next speaker, Robert Harrison, who will be talking about surveillance of health risks in contemporary work. And let me tell you a little bit about Robert Harrison before he begins. Robert Harrison is a public health medical officer with the California Department of Public Health, the Occupational Health Branch, and clinical professor at the University of California, San Francisco. He established the UCSF Occupational Health Services, where he diagnosed and treated thousands of work and environmental injuries and illnesses. He has designed and implemented numerous medical monitoring programs for workplace exposures and has consulted widely with employers, healthcare professionals, and labor organizations on the prevention of work-related injuries and illnesses. Also, Dr. Harrison has led many work and environmental investigations of disease outbreaks. He has served as a technical and scientific consultant to the federal OSHA and CDC NIOSH and was a member of the California Occupational Safety and Health Standards Board. His research interests include the collection and analyses of California and national data on the incidence of work-related injuries and illnesses. Dr. Harrison, you have the floor.
So first of all, I'm talking wearing a public health hat, and I don't like to use the word surveillance, even though that's the topic of this talk, because surveillance connotes, at least in the public health world, to the workers that I'm going to talk about today, pretty negative tracking, including the risk of harassment, firing, and deportation. So I like to say that everyone should be counted. So I'm counting, I don't even like to use the word tracking of workplace injuries or diseases, because tracking almost, means that like we're following you somewhere. But I like to say everyone should be counted. And what I'm doing is counting, because everyone, regardless of who they are and where they work, is a person and should be counted and identified so that we can find out how to prevent anyone else from getting sick. Next slide. I'm going to show you an example of occupational disease, which starts with a kitchen countertop. Starts actually with the renovation of our kitchens. And I bet a lot of people on the phone listening to Zoom have renovated their kitchens and installed a new kitchen countertop. A contractor comes and gives me a bid or an estimate for a new kitchen counter. I go and select a product, usually from a big box store. And then in about six weeks or so, a worker will carry a 500-pound slab up my front stairs and put it in the kitchen counter with the sink cut out, the little holes for my soap dispenser, get the curbs absolutely correctly. But there's workers who have sanded, ground, polished that engineered stone slab to bring to my house. And this is an example of a dusty engineered stone shop. This is also called artificial stone. This picture is taken by Earl Dotter, who's an award-winning, terrific photographer who had kitchen counter installed in his house and followed the trail of the installation from measurement to installation and went out and took some incredible photos. And you can see this guy who's polishing the inside of a sink cutout covered with dust. Now he's wearing a cartridge respirator and goggles, but you can imagine that the dust levels in the air of the shop are enormous, exceed probably 4 or 5-fold the safe dust levels for silica. And even with that respirator, it's probably not going to effectively screen out the tiny silica particles that are being inhaled into his lungs. Next slide. So this is where we go to buy the product. This has about 90% of the United States market. This is called artificial or engineered stone. Many of you probably will recognize this big box store. You walk in and The selection's in the back, and you pick out a little slab, you match it to your wallpaper or your tile or whatever. And then somehow, 6 weeks later, it comes in and you get this terrific product. Next slide. These are the major brand names. Many people will recognize Caesar Stone because that was the very first product. It's manufactured in a big factory in Israel on a kibbutz on the Mediterranean, and was first licensed for use in Israel. And then in the mid 1990s appeared in the United States, first in Los Angeles, imported by a gentleman who owns a company called Stone, etc., an Israeli-American who started an import business to supply this product to the Los Angeles market. Silestone's another product. This is manufactured by a Spanish company called Cosentino, and Cambria, which is the only US manufacturer. They're located in Minneapolis. Next slide. Next slide. So the first report of this disease appeared in 2012 in a journal called Chest, which is a very prestigious journal published by pulmonary doctors. And it reported 25 cases of very severe end-stage silicosis, the most severe scarring of the lungs caused by silica dust. Many of these patients required lung transplantation, and they were appearing in a Tel Aviv tertiary medical center. They were coming from small silica workshops, mostly in Jerusalem and Tel Aviv, mostly immigrant workers who were supplying the emerging middle-class Israeli marketplace. You can see of interest, the very first case was actually in 1997, which is quite telling because Caesar Stone was first produced in the early 1990s. And the first case only took like 5 to 7 years to appear and had terminal silicosis. By 2010, there were 25 cases. By 2012, these researchers published this paper. I read this paper. Our colleague, Paul Blanc, who works at UCSF, was a co-author. And I kept on asking myself, when is the shoe going to drop in the United States? When are we going to start to see these cases? Next slide. So on the top left, I published a blog with colleagues from the National Institute for Occupational Safety and Health. And you can see there's a little date here that says 2014 in the upper left. And basically we said, anybody have any information about these cases in the US? And lo and behold, somebody read this blog, a doctor by the name of Gary Friedman, who is a pulmonary doctor in Houston, Texas. And he said, well, I have a case that I'm seeing in my practice. So Dr. Friedman and I published the very first case report in the United States in 2015. That was called Notes from the Field. It was the Morbidity and Mortality Weekly Report. And that gentleman is actually shown on the top right in a New York Times article published by the journalist Barry Meyer, who was covering workplace diseases. And that man who has advanced silicosis became one of the leading cases that was brought to light when the OSHA silica standard finally passed in 2016. Now, we do a decent job in counting occupational injuries in the United States. Official statistics that are recorded by employers on what are called the OSHA logs. When somebody is injured at work, they report it to their employer. Their employer by law, by OSHA regulation, has to put it on a log. We do a reasonably decent job of counting things like amputations and back injuries and sudden lacerations and things like that. Although even data suggests that maybe an relative undercount depending on the injury. But we do a terrible job of counting and tracking occupational diseases in the United States. I could spend another hour talking about how we find long diseases of a long complication with long latency period, cancers, lung disease. But the short answer is we don't have a national system of tracking occupational disease. And so what was remarkable in this blog that I co-authored in 2014 was that somebody actually read the blog and wrote a comment in a blog about how there was a case. And that's how I actually found the first case in the United States. Next slide. So next, just advance underneath here. So the first case in California that I uncovered was from a hospital discharge record in 2017. And that's one of the ways in which we track occupational disease is just by looking at hospitalized cases, because when somebody's hospitalized, if we're all hospitalized, we get a diagnostic code, and the state of California keeps track of that. But you can guess that tracking occupational disease by hospitalization is just getting at the very tip of the iceberg, because you got to be pretty sick to be in the hospital. We dug up his medical records and interviewed his brother by phone, who told us that his brother had been working in a stone countertop fabrication shop beginning in 2014. Next slide, hit the advance, and was diagnosed with silicosis in 2013. By the time I found him in the hospital discharge record in 2017, it was 4 years later. Next slide. And it turned out he had actually died of silicosis by the time we were able to find him in the hospital discharge record. On further conversation with the brother, we learned that there was another brother of his who worked in the same shop, the same company, who had also died of what was described by the coroner as stone in his lungs. We were able to actually get lung tissue from the coroner's office, brought it to a specialist who found that his lungs were just full of silica particles, and he had something called alveolar proteinosis, one of the most advanced forms of silicosis. Along with colleagues from Colorado and Washington, we published another paper in the MMWR in 2019, which were a total of 18 cases in the United States. Next slide. Now, OSHA has a very strict silica standard. And before 2016, the permissible level was 250 micrograms in the air. And that was cut by 20% in 2016 to 50 micrograms per cubic meter. Don't really fret about or pay attention to what the number means, but it's very low and is set to protect against most cases of silicosis, as well as lung cancer, because silica is also a carcinogen. And the trigger or action level is 25 micrograms. That's when employers have to take action to use dust control measures, train worker, do medical testing, and keep medical records. Next. So as a result of this publication in 2019, California OSHA inspected about 100 companies throughout the state and sampled in about half of those companies for silica dust. And they found that more than half of those companies were over the OSHA permissible level for silica dust. And some were very, very high, way above the silica permissible levels. We also interviewed about 125 of those workers in these small shops and found not a single worker had ever had a silica medical exam. They had never been tested as OSHA required. They'd never had a chest X-ray or breathing test or questionnaire. Next slide. Remarkable was also that they were young. They were less than 40 years of age. They had been on the job for less than 4 years. A quarter of them were cutting stone dry. So if you're cutting stone dry, it basically, you never want to cut this stone dry. You're going to get levels of silica dust 4 to 5 times higher than is permitted. And as I say, they had never had silica medical exams. Next slide. So the pandemic hit in 2019. The publication came out, had 18 cases in the United States. OSHA did their inspections, and then the pandemic hit. And my research and my follow-up was almost completely focused for 2 or 3 years on COVID in the workplace. But I had heard informally that work in these stone fabrication shops continued unabated. In fact, business was better than ever. During the pandemic, there was a lot of work from home. There was excess income that we were able to save. Interest rates were very low, and there was a lot of kitchen renovation. And these shops were busier than ever. In May of 2022, Dr. Jane Fazio, who is a pulmonary physician in training at UCLA Olive View, came by a poster session presenting some of this research data and said, I have 20 cases that I'm treating in my practice, and I don't know who to report it to. And we said, Dr. Fazio, Jane, you came to the right place. We need to collaborate because she's seeing the largest number of silicosis cases of any doctor that I know of in the United States. And this is at a public hospital in the northern San Fernando Valley. Dr. Jane Fazio, you can see her in the lower right-hand corner of the slide with her supervisor, Nader Kamangar, who's the head of the pulmonary department at UCLA Olive View, has now seen 37 silicosis cases in her practice over the last few years, most of them in the last year. And I compare Jane sometimes to Dr. Alan Parmet, who saw 5 cases in his pulmonary practice in Missouri of incredibly advanced lung disease. All of his patients were exposed to diacetyl, which is the artificial butter flavor. Dr. Parmet reported his cases to the Missouri Health Department, who in turn brought NIOSH in, who in turn published a landmark study in the New England Journal of Medicine showing an elegant dose response between diacetyl and bronchiolitis obliterans, which is one of the worst lung diseases I've ever seen in occupational medicine. It's a rapidly progressive damage to the small airways of the lungs. Highlighting the importance of the alert clinician in reporting occupational disease. Next slide. Next slide. Just hit the advance, thanks. So here's simply a Google map of all the stone fabrication shops. You can see Olive View Medical Center in the upper part of this slide. This is a blown up shot of the San Fernando Valley in LA County. All the icons are stone fabrication shops. There are even more now that we've identified. Next slide. 40% of the cases that Dr. Fazio has seen have progressive massive fibrosis, and 15% have been fatal. And here's a lung CT that shows massive, all that white that you see in the lungs there is advanced scarring. Next slide. And here's just a simple epi curve. We've submitted this for publication and it's now under review. We hope to publish these cases and this case series in the next couple of months. Next slide. And with the California Labor Lab, with our colleagues, we've started a new project in which we're recruiting workers from these from these small fabrication shops and enrolling them in a study in which we're going to be doing low-dose CT scan of the lungs, which is a much better way to identify early silicosis. Next slide. One of the elements to success, and I think we're having success here. There's some mornings I wake up and feel very discouraged, but most mornings I wake up thinking, you know, I think we're really going to do some terrific work in LA County to highlight the problem of silicosis in these immigrant workers and improve our occupational disease detection system in California, that maybe we can use this as a model for a national system. And one of my hopeful moments is when I think of, and I'm just going to call him GR, who you can see on the left. GR's wife contacted me by email because he had been told that he had terminal silicosis by a primary care doctor. And his wife didn't want to take that answer. She did some research, Googled silicosis, found us at UCSF. And when I talked to GR, he was on oxygen. He had lost about 60 pounds. I got him referred to Dr. Fazio, who's on the right, who was able to facilitate getting him onto health insurance, referral to Cedars-Sinai. And 8 weeks ago, GR had a bilateral lung transplant. And you can see a picture of him next to Jane on the right. And when I compared these, I had to do a double take to say, is that really the same person? It is the same person. He now has a new set of lungs. It's not a long-term cure by any means, right? There's, you know, it's going to have to be carefully monitored. I also, when I look at that picture of Jane, think they are exactly the same age, those two. And they're just by the grace of God go I, is what I think when I look at that picture. You know, we talk about the hierarchy of controls in occupational and environmental health. And at the very top, we need to work on product substitution. So we need to get safer products out on the market. Our colleagues in Australia have called for a ban on engineered stone, and they may get it in Australia. Community, employer, and worker outreach. And with folks like GR and Jane, we're starting to reach out and talk to other affected workers. Registering these shops and getting Cal OSHA, doing medical testing, and then making silicosis a reportable disease. Next slide. We've done a lot of great social media outreach. This is an article in Public Health Watch that came out in December. That's Dr. Fazio on Univision. This has about 2 million views. This was done in Spanish. Next slide. These are all the shops in LA. LA County has taken this on as a major public health issue, incredibly inspiring engagement by the Director of Public Health, Dr. Farrar in LA County. They're going to send out their public health teams to visit these shops. Next slide. And then finally, I pose this question. This is a bust of Bernardino Ramazzini in the town square of Carpi, Italy, which is his birthplace, with a thought bubble on top of Bernardino's head that is translated from Italian into English is, "What took so long?" Bernardino asks, because he diagnosed silicosis 300 years ago. I don't think Bernardino would have realized the scale of global migration, international capital flow, and this new technology. And that's our challenge, is to honor Bernardino and say, Bernardino, we're going to get rid of this silicosis. It's 300 years later, but we're still working on it. Thank you.